Greetings, picking up where we left off for Kinesiology 236, Chapter 8. We are going over the hip joint and pelvic girdle. Where I left off was the psoas and iliacus muscle. And you'll notice where the psoas originates on the lumbar area of the spine. It comes down and merges with the iliacus muscle, and they form what is called the iliopsoas muscle. Believe me when I tell you, many people, when they have back pains, can be traced back to some type of iliopsoas issue. There's a bit of a triad that goes on between hip flexors, hamstrings, and low back pain, and you have to be aware of this little relationship between the hip flexors and the hamstrings, meaning anterior, posterior sides of the body, and how some of those attach on the lumbar area of the spine, while others you'll see attach in the pelvis, and that'll cause anterior, posterior pelvic tilt. Remember, have the visual of people walking out of a cycle class, almost waddling out of a cycle class because their psoas and iliopsoas are so damn tight from doing hip flexion over and over and over and over and over and over again in a cycle class. You'll get the picture. Moving on. I took the slides from the book and I took the images from the book and I overlaid them for your benefit. So when you look at this with the gluteal region, it extends and rotates the hip. Okay, great. And they gave you a couple different pictures. What I did is I tried to break this out where I underlined glute max and glute med, so you can see glute max, how it originates on kind of the SI joint there and part of the iliac crest. And you see the border there where it originates and where it attaches on the femur. And you look at glute med begins where glute max kind of ends, if you will, and then glute med is not attached on the femur out here like glute max. Glute med is attached here, more in the greater trochanter area. So if you look at terms of straight movement and movement analysis, glutes are the powerhouse, man. They are the powerhouse of the body for creating power and lower body strength. And glute max originates on a broad area and attaches on a broad area, and it's used in hip extension, whereas glute med, it's a smaller area, it attaches in a different area on the greater trochanter, and it's not used so much in extension, but a little bit more abduction. Okay, and you look at this, you have the pictures here, abduction, some internal rotation, some external rotation, but the biggie it's known for is abduction. I then broke it out into glute mini and then TFL. So mini runs deep to maximus and med. Those two are superficial to mini. And if you look at where he originates and where it attaches, notice it's different than glute max, but it's pretty similar to glute med, and they're going to have a little bit of the same movement patterns when you look and evaluate these muscles. TFL is a little bit different animal. That's a two-joint muscle, runs from the lateral aspect of the hip, lateral inferior aspect of the hip on the iliac crest, down across the hip joint, and TFL runs down and runs across the knee and attaches on the tibia. These guys I'll get into in a little bit are hugely important when you start talking about working with valgus dysfunction in athletes and working on glute dysfunction and weak glutes. These are the biggies. Usually people go right into squats and they need to do these first. Okay, so with these guys, if you look at how they originate and where they attach, they're all external rotators. And so often, if you remember valgus, right? Valgus is that kind of knee in position where the knee makes an L. That's how I remembered it to get me through school. You'll see oftentimes coaches will go right towards, well, they have weak glutes. We're going to go right to glute max. We're going to do squats, and we're going to do squats over and over and over again until we get the powerhouse nice and strong. What they're missing out on is these are not used as much in external rotation as these. And so when you have somebody who is in valgus, they have a slightly internally rotated femur and it's adducted. So you really want to focus on these first, right? If you have somebody who has extreme valgus, focus on the external rotators first, doing clamshells with the heels together in side lie position, maybe working some band work to try to work these to get these guys nice and strong, to take a person out of valgus, have them in a more linear position, meaning hip, knee, and ankle, and then get into actually working on glute max type activities. I can't tell you how many times I've seen this done backwards, where people try to work glute max first. We're going to work squats to get the glutes, and really what they have to focus on are these guys. The powerhouse will come, no doubt about it, but you have to focus on these guys first. With the muscles, they divide them into three main compartments, anterior, medial, and posterior. And what I tried to do here is I tried to break this out where you have the anterior compartment. I underline those in pink for you. You can see them on the front side of the body, right? So here's your medial line, here's the anterior, here's the posterior side of that, here's the lateral and medial side. And when you look at the knee joint and the muscles that come down into the thigh itself, you got intermedius, lateralis, rectus femoris, vastus medialis, sartorius. And so you have these quadricep exercises. Now, if you think back with the quadricep group, we talked about there was a two joint muscle that runs down that also does knee extension. Now, I mentioned you have the vastus guys that come to the party to make that movement happen, but they're single joint, whereas rectus femoris is a two joint. And then here with the posterior compartment, I did the same thing with the pink line, so you can pick those out a little bit easier on the rendering here. But you get semimembranosus, semitendinosus. And sometimes it's kind of hard to pick out and differentiate the two because semimembranosus, it runs and it almost kind of bifurcates, if you will, where you have part of it is lateral to semitendinosus, but semimembranosus also runs a little bit medial to semitendinosus. So it's a little bit quirky, and you'll see that here in a second, some of the other renderings. And then when you have adductors, I did the same thing over here. You got those in pink for you. That should help you out. And what I want to get back to is the person who waddles out of the cycle class, when they're waddling out of the cycle class, because if you overlay the muscles here that we talked about, psoas, iliopsoas, right, because you have iliacus and psoas, they originate right in this region, L1, 2, 3, 4, 5, right? And they come down across the hip joint. So if you can think of this in terms of hip flexion, and those muscles get super strong and are pulling on L1, L2, L3, L4, and L5 over and over and over again, and those building blocks become somewhat compromised, well, that in turn will then cause neurological dysfunction through these nerve roots, and you'll end up with different neurological issues further down. Now, I can tell you from experience, a lot of the people that you'll come across will have some type of neurological dysfunction like L3, L4, L4, L5, but especially L5S1. That's usually the biggie for most people. And some type of nerve root dysfunction that'll end up with nerve dysfunction down into the leg and down to the foot. I left these up here for your benefit for psoas, iliopsoas, so you can see them and you can see where they originate, where they attach. And same thing like with rectus femoris, that two joint muscle we just talked about. You had the other ones that come to the party to help with knee extension, but this is your two jointer right here for knee extension. Sartorius, right, you're going to get some flexion of the knee out of that, but it's flexion of the hip, and he's a two joint as well. But notice he's flexion of the knee, whereas rectus femoris is extension of the knee. See that? If we pull this down a little bit further, pectineus can be grouped in with the adductor group, as well as adductor brevis, adductor longus, and adductor magnus. Now, those are all part of the adductor group, and you can see how when you look at magnus, the size of it and the length of the actual attachment versus brevis and longus, how it's much smaller. See that? Longus, the length of this adductor compared to the length of this adductor is different. And then you look at magnus because it's so dang big. Gracialis. Okay, got it. Obturator foramen area. All right, it's in the ramus pubis. Further down here, duration of the hip. Let you kind of soak that in for a moment while I breeze through this. Semimembranosus. Fun story about semimembranosus and semitendinosus. I mentioned they're kind of tough to differentiate sometimes in terms of membranosus, but notice how membranosus is sitting out here, or in here, I should say, because this is the midline of the body. So this would be the medial side of the body. This is the lateral side of the body in posterior view. You know this because the leg, the rendering is on the right side of your screen, so you know it's a posterior view. But notice how semimembranosus is running down, and we get to semitendinosus, where he runs down. He runs almost straight north-south, crosses the knee joint. He runs kind of into the midline of the thigh and then back out to the midline of the body. And you'll see in other renderings, this part of semimembranosus will be revealed compared to semitendinosus. And that was the one way I remembered membranosus versus tendinosus. Okay? You can also see a little bit of a difference in terms of origination in the rendering, if you can see that. Biceps femoris, same general location as membranosus and tendinosus, more specifically membranosus. Comes down, crosses out to the lateral aspect of a knee, out towards the tibia. And then actually mostly on the fibula. You can kind of see there's a little bit on the tibia here and then some on the fibula. Great. Got glute max, we talked about him. Runs along this border here, nice big border, nice big attachment out here, big beefy muscles, usually known as a powerhouse. Glute med takes over where glute max ends along this ridge here, and glute med attaches out on the greater trochanter, used more in abduction. Right? Glute min runs deep to the other two, and its actual origination is no longer on the crest, put in here. All right, so you're talking about on the ilium itself, and then comes out here and it's on the greater trochanter. Now we go ahead and go to a anterior view, TFL, tensor fasciae latae. We talked about him a little bit earlier. It comes down across the knee joint, it's a two joint muscle. And then piriformis, gemellus superior, gemellus inferior, etc. These are your deep six that you want to focus on, that we want to focus on first before we load somebody up with heavy squats. Now I'll rip through these real quick. You have psoas, iliopsoas, etc. What I did was I tried to numerically organize these for your benefit. So you'll see 1, 2, 3, 4, 5, 6. 1 and 2 are these two, psoas and iliopsoas, as they come down in this region. And then you have number 3, rectus femoris, pectineus, sartorius, and then TFL, tensor fasciae latae. And notice how the difference you have with sartorius and TFL. Sartorius runs down and comes down the medial aspect of a knee, while TFL comes down and runs down the lateral aspect of a knee. Glute max, we already talked about him, and then we get into biceps femoris, talked about that. Semitendinosus from membranosus, but notice this will start to get a little bit wonky here when you get into some of the other agonists, because they do double duty, right? So glute med, right, here, but TFL, we saw a little bit earlier, tensor fasciae latae, number 6, right? He's used in hip flexion, but TFL is also used in abduction. So that's why you see it here. That's why it's number 6 again. Glute max, right? Same story. And then you have glute min, number 12. And again, glute here, rotation-wise, glute med. TFL again shows up as another agonist in another group. So it's kind of unique with TFL. External rotation, glute max, and then you have a deep 6. And this is where I always make that point, say if you want to work this one and get this guy nice and strong, make sure these guys are pretty strong so you can stabilize this joint. Got it? Get it? I hope these videos help you. Please send me an email. If you think they're awful, they go too fast, you need me to break out the slides into, like I have today, 2 separate presentations, let me know. Also, you guys need to make sure you stay on top of your check for learnings and your homework. I don't want you to get to the second week of May and all of a sudden you're in a panic trying to get everything done. I've loaded up a ton of homework for you guys, some exams as well. Don't wait till the last minute. That type of homework load will crush you. Don't let it go. So please send me feedback. Let me know what you think. If you need something else done differently, the layouts, whatever, I'll take whatever suggestions I can get. We're in kind of a unique teaching environment, and part of this process, I always believe, is to hear what the students have to say and implement accordingly. Hope you guys are doing well. Have a great one. Be safe.